Sure. Hi, Megan.
Hi, I hope everybody's gotten their lunch and their provisions, and it's so delightful to see that people have gotten to know each other over the years and are enjoying each other, because many of the great things that have come out of this we thing that we call the Right Care Initiative are all about people getting to know each other, brainstorm together, come up with new ideas. Our co-chair, Dr. Carol Zaher, cardiologist with HealthNet, and I were talking for over 3 hours last evening. We just got carried away talking about how we could reduce heart attacks in Los Angeles. And what a wonderful thing to have such intellects coming together around a great public purpose. And today we're very lucky to have some of our original Right Care Initiative enthusiasts from our original pilot project in San Diego with us, including Dr. Jim Duddle from Kaiser, who is the champion of the ALL Bundled Medication Therapy Protocol, which is aspirin, lisinopril, and Lipitor, or it's generic.
Lipid lowering.
Lipid lowering, well. Of course, it's a generic bundle at this point in time. It's a very inexpensive way to drive down heart attacks and strokes. And we are so grateful for these long-term relationships that have developed something truly spectacular for not only the people of California, but this is spreading nationally thanks to Dr. Alan Fremont's leadership of documenting at a very detailed level what interventions were done, what the heart attack rates were in our initial pilot community in San Diego, and then how they changed after we started as a community, just thinking up what can we do to lower heart attacks and strokes. And so it's one thing for activist Hattie, who has just enough information to be dangerous, that gets people excited about doing this great public work. It's another thing to have an MD, PhD, who believed in me from the first moment we met, and he was always trying to ground me in the data. And frankly, I really did not understand why we needed so much data until years later, the Office of Statewide Health Planning and Development data indicated that the rate of heart attacks after we started declined by 24%. And then Alan was able to connect the dots, Dr. Alan Fremont, through his amazing dedication to the details and getting them right. And he kept us all on the right path, a combination of enthusiasm and rigor. So RAND, and Dr. Jeffrey Wasserman, the head of RAND Health, is here with us today, has been helping me to take my enthusiasm for improving public health back since we worked on bioterrorism preparedness together starting in 2002. And I had forgotten how far back that we've been working together. But it was wonderful to be able to make that connection. Why don't we have Jeffrey say a few words of welcome, and then we'll turn back to
Okay, well, thank you, Hattie. And frankly, I would not have recognized you out of the lineup because I haven't seen you since 2003, probably. But the process of elimination, knowing that there are really very few people in the world named Hattie. In fact, the only other Hattie I know is the Bob Dylan song, Hattie Carroll. So it didn't take me long to put together the fact that we knew each other. So welcome to RAND. I'm Jeffrey Wasserman, as Hattie said, Vice President and Director of Rand Health for the next 10 days. And then I retire, So it's a pleasure, though, to be here to welcome you and to join Alan and Hattie in a picture for the award. So Hattie is basically saying, I'm here for eye candy today. So she said, I want you in the picture. And, listening to you talk, Hattie, it occurred to me, you're an advocate and an activist, what have you. And I think often when we're a research organization that's committed to having an impact on the world. And I think often our researchers mistakenly think that, you have to leave the passion aside and just focus on the research. But I think to have policy change and really to improve health, which is our mission at Rand Health, it's often, very advantageous to couple our research and analytic capability with people like yourself who are advocates, activists, and so on. And I always tell, we have a graduate school here, and I teach, and I always tell our students, it's okay to be an advocate for an idea or a solution to a problem, provided it's grounded in analysis, and that you're not coming to a problem with a solution, ahead of time in mind. You come with an open mind, you try to be as objective as possible, but once you do the analysis and you have a sensible solution, it's, I think, important to couple that with passion and advocacy and so on to change. So it's a pleasure to be here, and as I said, to join you in delivering this award to Ellen. So thank you, and welcome. Enjoy the lunch.
This just hardly captures the incredible essence of the luminary, Dr. Alan Fremont. He has been through so much in supporting this work, and it was like we knew each other forever when we first met. He just completely got what I was talking about. So there I was, when I started this project, I was in the executive office of the director of the Department of Managed Care, the regulator for managed care for California. And I was asked to pour through thousands of pages of data, which I did night and day, weekends. My husband can attest to that. And I was just so disturbed by what I saw in the publicly available data about the metrics for heart patients, diabetic patients, hypertension patients. Because as many of you know, when I was 15, my mother, who had uncontrolled hypertension, died suddenly of a stroke. And so when I saw that about 40% of known hypertension patients in managed care companies who had insurance, who were identified by their providers as having hypertension, were not in good control. One of the first calls I made was to Rand to say, wait a minute, how is this possible? Is this accurate? And what can we do about it? And Alan immediately came to my side and said, we can figure this out. We can do something about this. And he just very calmly helped with work groups and data groups. I call him the data whisperer because he could get data out of people that no one thought possible. And it was his doing that despite some very difficult struggles that has resulted in this week being published in a national journal called Health Affairs, that after applying the science, the known science in San Diego, with the help of many scientists and passionate advocates for LDL 100, for HbA1c8, for hypertension 140/90. Those are not radical interventions. But that resulted in a reduction of 3,826 fewer documented acute myocardial infarction hospitalizations, which was a 22% sustained decline over a period of 6 years. And this would not have been documented for the purposes of changing how care is delivered not only in California, but I would have to say internationally. We have a formula, we had a hypothesis, we implemented that hypothesis, let's get those patients into good control through Alan's tender loving care, working with medical directors like Dr. Jim Duddle and Dr. Scott Flynn, who was planning to be with us, I'm sure he's just delayed. And with the patient advocate, Liz Helms, was able to do a very scientific process of creating a trusted environment for blinded data sharing, where on a very regular basis, much more so than what is available through publicly available data, but in using the same metrics as that which is publicly available, was able to do somewhat of a plan, do, study, act, interactive, dynamic process where each of the physicians was coaching the others on how did they get their difficult patients into good control. And this not only created a special club among those people who never knew each other. And they're now, I would have to say, almost like a family. They love each other, they support each other, and they've had such an impact on reducing particularly heart attacks, but also strokes, statistically much more significantly for the heart attacks. And what we have to say is, what we documented in this paper, and there were 8 co-authors, Alan led us bravely, even on Easter Day, we were working on this for many long hours, to the point where we have, I think, an outstanding paper that's now been published and recognized in Health Affairs that others can then build on, including the Los Angeles community. And so we'll be talking about planning a little bit later. Alan, I don't know whether you would prefer that I run the chronic care video or not. I'm going to follow your...
You're talking about the one that you've shown previously? Or
that Liz did. I've never shown it.
Oh, either way is fine.
You're okay with it?
Yeah.
Brian, could you cue that up? I just want everyone to realize that during the time that Alan was helping us, I think it is something to recognize that his personal struggle helps him to be a better patient advocate too. Although he's the ultimate MD, PhD, Harvard scientist, he's also grounded in such a love of patients, and that's, I think, what gets us to this day. And so we'll do photos after this, if that's okay with you.
Alan Fremont was diagnosed with lung cancer in 2010.
It was a surprise because I never smoked and had been otherwise fairly healthy. And not only did I have lung cancer, but it was fairly advanced at that stage. It was metastatic lung cancer. I had several liters of fluids in my lungs.
Alan says his life expectancy at that point was 6 months to a year. He went through both chemotherapy and radiation treatment at Kaiser Hospital in West LA, but that didn't seem to make a dent in this cancer.
I found out that I had a previously undetectable type of cancer called ROS1, or the mutation, and that there was a nearby treatment at UC Irvine.
In an unusual arrangement, Kaiser approved Alan to participate in the ROS1 research treatment trial.
They didn't know if it would work with me, but they opened it up for 10 patients, and I turned out to be the second person in the world that they tried it on. and it worked very, very well. And it's a type of treatment called precision medicine, or genetically targeted medicine.
Because of this groundbreaking research and innovation, Alan and thousands of others are able to live lives full of promise and hope.
What's happened in cancer care, or parts of cancer care, is mind-blowing. But now what was completely new for me is now FDA approved, and here I am 7 years later and living a really good life.
So the fact that through that, he got this done makes him truly the bionic man. So Alan, Fremont, if you would please accept this Lifetime Achievement Award, we would be ever so grateful.
Thank you. You know, when getting awards like this is very gratifying, and it is. I am honored and flattered, but what I really want you to get and take away from this, and even with the context of, you know, as a sideline, I've had cancer during most of these last few years, is part of why I signed on for this work originally and then stuck with it is it was different from many of the research projects we sometimes do or get to participate in. It was truly looking to be a collaborative, collective effort of a lot of stakeholders who weren't seeming to just go through the motions. And there wasn't actually a clear path to exactly how to do this, whatever we were trying to do to go ahead and improve the rates. I mean, we knew some of the things, but exactly how to implement it, especially in a competitive environment, was unknown. And what's made it worth it for me and for others at RAND, and I think for many of you who are participating at different stages of this in LA, and some of you have been here from San Diego way back, is it's sort of chicken soup for the soul. It's fulfilling. It is. We have a lot of requests, and it's not always. Some of them are unreasonable requests that are pretty stupid to take on or do, and yet the end goals inspire us, or can, and some of us, the medical directors. I mean, that's one of the things I've appreciated the most in terms of the different systems playing together, and then different people at different levels within different systems playing together and across, and just that is the model of healthcare that I hope we see throughout the country, and it's. I went into training for that, for both research and for medicine, with that expectation there, and I think part of what has been the magnet for in San Diego, and I think is we're seeing many early signs of this in LA, is people you're not just committed to it for your organization, you're not just committed to doing this because it seems like a nice volunteer effort. It is, these are some of the things that we're talking about here in the kind of collaborative work or improving population health is what we signed up for. And so I think the final thing I'd say is it just takes time to show some of these effects, and the main thing is to stick with it. And some of it is rocket science, some of it is brilliant, some of it is just showing up and being there. So anyways, thank you very, very much.
Can you do camera? Jim, would you come up? And let's take off our name tags. And Liz, why don't you come on up? And Chloe, of course.
I just want to get his ring badge. They're going to want you to find out. They definitely want it.
Liz, take your name tag.
Go ahead.
In the center. There we go. Thank you.
Thank you.
So with that, I'd like to turn the meeting over to our co-chair, Dr. Carol Zaher, if she would introduce Tony Kuo. Would you join me, Carol?
It is afternoon. Good afternoon. Well, I'd like to introduce our first speaker today, Tony, who's, oh, thank you. And because of my age, I have 2 sets of glasses. And Tony's been around a while, and I actually started with RightCare back in, I think, 2008, but then I had to leave for a bit. But Tony, I think you're a more long-standing member of this group, right? And I'm going to read a little bit of your bio here. Senior Health Office, Director of the Office of Senior Health in the County of Los Angeles, and the Deputy Director for the Division of Chronic Disease and Injury Prevention. Okay, you have a lot to cover there. So we're hoping in this interesting talk that you're going to give, where you can elaborate on some of the issues that you do in your role, and show us how they relate to best practices. And as Dr. Fremont said, hopefully we can take away from that how to put it into practice, because that's where the rubber meets the road, I believe, in what we do. And sometimes, as you mentioned, it is slow starting and starts that stop, and but if we persist, the goal is out there to be achieved in some way. So Tony, I'm going to let you come up. And we'll see that I have a lot of good questions for you.
Thank you very much. And I think my talk is exactly why Dr. Fremont's work is so important, because I think the idea of using data to drive policy. So I'm going to talk, Hattie asked me to talk a little bit about what public health does and how that actually relates to what we do here with the RightCare initiative. And the question about what public health does, of course, is a tough question, because I get asked that and I don't generally have like the best answer, because most of my families and relatives thinks I actually inspect restaurants. And then I assign them a grade. But generally what I hope to do today is to just give you a sort of that upstream, where I think of my participation in this collaborative and public health perspective as more as we're that upstream arm of what everybody here has been diligently working towards in the sort of clinical and individual setting. Wanted to show you some data that we've been tracking and why we're always looking for data to help us drive policy. And then at the end of it is that for us, policy development and also trying to ensure that we have quality services to really basically deal with, to us, we're consumed with the three key things, right? If we know that from a cardiovascular disease standpoint, if we could just help people stop using tobacco, live healthy lifestyles, and even more importantly, control blood pressure, we could really reduce the risk of and the cases of heart disease and hypertension. Of course, these three sounds very easy to do, but sounds great, but they're very hard to do actually in real life. And then I want to share with you some of the existing and also forthcoming state and local initiatives that actually kind of plays into this. So as you know, LA County is very interesting. I tell people that we sometimes don't listen to the state because we figure that whatever happens in LA County, the state follows anyway. And part of that is we're very large. We're like 10.3 million people. We're actually larger than 42 other U.S. states in the country. And of course, we're broken down. This is to show you that at least geopolitically, we're broken down by service planning areas. And you can see that we have almost 80, we have actually 88 cities, and one of them is, of course, the city of LA, which by itself has almost 4 million people. But we also have large rural areas, and you see all that white space is unincorporated areas, and they're actually becoming more and more populated, partly because as more gentrification and housing issues, some of these social conditions that actually also affects cardiovascular health begins to change. A lot of people are actually moving into those areas that were previously rural. So, Department of Public Health, our vision, healthy people in healthy communities, fairly simple. Mission is really to protect health, prevent disease, and in recent years that means chronic diseases like cardiovascular disease. And our department is also growing. Our annual budget is about $1.3 billion, and I'm one of about 4,000 employees. And although, like I said, I'm not a food inspector. Our three core functions, and this is where data kind of comes in, it actually plays into all three of our sort of core functions that we do. One is, of course, disease surveillance and health assessment. Policy development, we do a lot of work where we require data to kind of convince both our county board of supervisors, but many of our municipalities, government, to actually pass policies that addresses those three risk behaviors that I had mentioned. And then assurance, we oftentimes, again, not to, the inspection of food is one thing, but we also do things like, at least in senior health, like health facilities actually inspect nursing homes. And so we do play a role in trying to ensure that quality of care and some of those standards are actually adhered to. So, burden of cardiovascular disease. This actually is from OSHPD data, and I know this is kind of a colorful slide, but it's just to give you an idea. If you look at acute myocardial infarction in terms of per 100,000 adults, and you actually map it, there's quite a lot of variety, right? And some of the highest rates are, not too surprisingly, in areas where, for example, in SPA, sort of 6 and 8 area, where you have low-income neighborhoods, in more rural areas up there in SPA 1, and then some of the metro area in East Los Angeles areas, SPA 4 and SPA 7. You look at some coronary sclerosis or heart disease, and you sort of see almost a similar pattern. And we also, tracking like metabolic syndrome and diabetes, and you can see sort of the same thing. And you could probably figure out by now that I like colorful maps. So you're gonna see a whole bunch of them. This is based on our LA County Health Survey. If you ask people ever diagnosed with diabetes, and again, you kind of see that concentration of diabetes prevalence. And not too surprisingly, we've known for a long time that a lot of these are interrelated. You know, obviously, as diabetes has been going up, obesity's been going